When we look at kyphosis, this is a degenerative disease that we would see similar to that of arthritis. It leads to more fractures in the spine, secondary to osteoporosis, or this brittling of the bone itself. And then you see oftentimes slipping of one vertebra forward onto another. And these are kind of some of the impacts that we see with kyphosis. Now, depending on the curvature will depend on how much or how aggressive our general management or our treatment is going to be. So when we look at this, if our curvature is less than 20%, if it's less than 20%, we're going to observe with regular checkups every 3 to 6 months. So that's pretty straightforward, right? Less than 20% curvature, we're going to get regular checkups every 3 to 6 months. Now, when we have curvature that's greater than 20%, we're looking at these patients now having braces, surgery, and the alternatives. So we'll kind of go through the breakdown on those. So when we look at braces, this is our first line of defense. This is what we're going to attempt, and this is what we're going to try first. And these braces, we're going to talk about the different names of the braces here in just a second, but they have a specific name. When we look at the braces, what they're trying to do is they're trying to hyperextend the spine and limit the forward flexion. So trying to eliminate how much that vertebrae that's slipping forward, trying to limit how much it slips forward so that there's not so much forward curvature with the kyphosis. When it comes to your adolescents that have idiopathic scoliosis, we're going to take a close look at them as well. When we look at the infant and juvenile, most likely these are going to come from a source of some sort of neuromuscular disorder. So we can kind of look at the adolescents being the bulk of that 80 to 85% that are from the idiopathic category. And then we look at the type, the type of brace is selected based on the age, specific characteristics of the curve, and patient's willingness to tolerate the brace. This is a hard brace. I'm going to tap the back of my phone, but it is a solid brace that these patients have to wear, and they wear them all the time. And sometimes there's some rubbing, sometimes there's some discomfort that's associated with wearing these braces all the time. So depending on what the patient can tolerate is what they will use. When we jump into surgery, we're talking about spinal fusions. Okay, this places a piece of bone between two or more of the vertebrae, and you don't get the same level of flexibility that you would with these spinal fusions. Other surgical placements or surgical interventions is a rod instrument. It's a metal instrument that's surgically inserted to prevent any further curvature. One of the gals that I graduated with in the respiratory therapy program, she had the surgery when she was a kid to have the rods placed so that it limited her scoliosis. So that was really interesting to kind of go through these topics, especially whenever you have somebody that's lived it. Alternatives are going to be electrical stimulation or chiropractic manipulation, some stretching and exercises. These are all alternatives when it comes to interventions or management of kyphoscoliosis. When we look at the three different types of braces, they are called the Charleston, the Milwaukee, and the Spine Core. Those are the three different types of braces that we use. I'm not going to get into which brace is specific for which condition. Just be able to identify these as braces for kyphoscoliosis. So you might see something that is, which of the following is not a name for a typical brace for kyphoscoliosis. When we look at our patient, when our patient comes in with this condition, with this disorder, look at how bad this curvature is. It is a very, very dramatic curvature. You see that there is a mediastinal shift. You see that there's a tracheal shift. You see that there is compression of the lung on this side, and this lung is abnormally shaped as well. But this is the lung that gets the brunt of the damage because everything is being pushed that way. So this is a very significant kyphoscoliosis here. When we look at the patients, when they come in, their vital signs are all going to be increased with the exception of their temperature and their saturations. Typically, these saturations are going to be decreased. When we do our IPPA, your inspection is going to be starkly different than somebody who does not have kyphoscoliosis. These patients are going to complain of pain and anxiety. They're going to have cyanosis. They're going to have chronic cyanosis. So when they have chronic cyanosis, it will impact their digits, and your fingers will end up with digital clubbing. We talked about the tracheal deviation already. You're going to see that. You're going to see asymmetrical chest rise. This right lung is not going to move nearly as much as this left lung will. You're going to have dull percussion notes on this side. You're going to have resonant or maybe even hyperresonant on this side from the alveolar hyperinflation on this side. Breath sounds will be diminished on the affected side. You could have coarse crackles, or you could even have wheezes over here. This side will be vesicular. You may hear this left lung even underneath the sternum. So you're going to have lung fields that are abnormal to what you're used to. When we look at the ABGs, if these patients with a small curvature, they're going to have acute alveolar hyperventilation. When these patients have a large amount of mucus that's accumulated, they are going to be able to transition into acute ventilatory failure really quickly. When we look at their PFTs, everything's going to be decreased. Flows, volumes, capacities, everything's going to be decreased. Hemodynamics, again, you have all of the issue happening at the lungs. So the right side is going to be increased, the left side is going to be normal, if not decreased. Clinically, these patients are going to present with peripheral edema. You'll see some JVD. They're going to have cor pulmonale, right-sided heart failure, and hepatomegaly, and even a tender liver. Whenever I press on this, I'm going to see that JVD getting worse because you have extra blood here in the jugular veins and in the liver. So whenever you press on this, all of that blood is going to move up the inferior vena cava and into the superior vena cava and into the internal jugular vein. You're going to have all of this backing up of blood because of the increased resistance that is happening from the right side of the heart getting blood into the lungs. So that area between the right side of the heart and the lungs is the pulmonary artery or the pulmonary trunk. And what are the three things that will impact the pulmonary vascular resistance? pH, CO2, and O2. If these patients are struggling with hypoxemia, they're going to hyperventilate. Well, how long can they hyperventilate? After they tire out, that pH is going to lower secondary to the CO2 elevating. So you lead your right side of the heart having to pump harder because of an increased pulmonary vascular resistance. That right side has to pump harder, and it will eventually get to a point to where it won't circulate blood nearly as effectively as it should because that right ventricle has been over distended, and it's that hair tie or that rubber band that no longer has the elasticity, no longer has the snapback, and can move blood through the system. Last thing that we're going to look at here are the respiratory interventions. We talked about the general management with the braces, surgery, and alternative methods, but these patients are going to struggle with hypoxemia. We're going to need to put them on oxygen. They're going to struggle with secretion management. We're going to need to do all of our airway clearance techniques, whether that is the acapella, whether that's the aerobica, whether that is the vest, whatever it may be, manual CPT, percussors, any sort of PEP therapy to help with that lung expansion, especially on the affected side. And when they do go into acute ventilatory failure, we need to be there with the mechanical ventilation, whether that is invasive or non-invasive. We need to be prepared. And we need to recognize that these patients are going to have decreased volumes and decreased capacities. And all of that volume that's going into that endotracheal tube, it's going to want to go to the good lung first. I cannot over-distend that good lung and then sacrifice the bad lung just because fluid dynamics and the law of fluid dynamics says that the flow is going to follow the path of least resistance. I need to be aware. When I look at that right lung, it's going to be poorly compliant and it's going to have an increase in airway resistance. When I look at the left lung, it's going to be hypercompliant perhaps, or have a normal compliance. And if there's not any secretions accumulating on that left side, then they're not going to have an increase in airway resistance. Whenever I look at my chest cavity as a whole, whenever I look at the compliance, I cannot isolate the right lung from the left lung unless I do something crazy like independent lung ventilation. And I don't know how often we're doing that, to be honest. So whenever I drop the ET tube because this patient's in ventilatory failure and I start to ventilate, I need to recognize that the compliance is a measurement from across the spectrum of the lungs. The airway resistance is a look at the airway resistance across the spectrum of the lungs. So I need to make sure that I'm doing what I need to get the patient mechanically ventilated effectively and safely. But that's what we have when it comes to kyphoscoliosis. We kind of broke down scoliosis, broke down kyphoscoliosis. We talked about etiology, epidemiology. We talked about the clinical manifestations, the signs and symptoms that the patients are going to come with, and the pathophysiology, along with the diagnostic tools and the treatment that it's going to take for these patients. So we'll see you on the next one.